Warm welcome to everyone. This is SM Abdullah, member in Health Economics Research Network HERN in Bangladesh. With a view to remove the skill barriers needed for research in health economics, the Center of Health Economics in the University of York, UK, in collaboration with ARK Foundation and Bureau of Economic Research, University of Dhaka, built the Health Economic Research Network in the year 2022. The network aims to bring together local and international partners, experts, economists, scholars, researchers, and academicians from the field of health economics. Through research facilities, supervision, and training, the network actually intends to bridge the knowledge gap, create a platform, and strengthen partnership among the local researchers to carry out context-specific research in the field of health economics. On the capacity building front, as a regular activity under the umbrella of Health Economics Research Network, this is the second monthly webinar arranged by this network. I appreciate all your kind presence despite the busy schedule. I believe the upcoming 1 hour is going to be interactive and knowledge enriching for all of us. Today, we have the honor of presence of Dr. Abdu Yazbek as our distinguished speaker. He has many hats. Dr. Abdu is a lead health and labor economist with 30 years of research experience in the arena of development economics. He served as a program leader and lead trainer for the World Bank Institute. He is an associate editor of the Journal of Health System and Reform and faculty at the Johns Hopkins University Bloomberg School of Public Health. Dr. Abdu's today's discussion will distill the main policy messages from the last few years of published literature on the applicability and relevance of health insurance systems for low and lower middle income countries. All health financing systems graduate from a system dominated by out-of-pocket financing to a dominantly pooled resources system, but there are different ways this accomplished, and the research is fairly definitive on what does and what does not work well for developing countries. I believe the upcoming discussion in the next 1 year is going to, elaborate all these sort of stories from the recent literatures. And also, today we have the honor of presence of Professor Rumana Haq, convener of the Health Economics Research Network, and at the end, we will have the vote of thanks from her. Without much delay, I would like to invite Dr. Abdu to take us through his today's presentation and enlighten us with his own work. Thank you so much.
Thank you, Abdullah. It's lovely to be with all of you. I am currently in Europe, so it's afternoon for me. For those of you in the subcontinent, good evening. I'm really excited about this conversation. If you've seen the title of my talk, it asks a question. So I want to test out your voting techniques. So I understand in Zoom, you could raise your hand. So I'm going to ask you first to all of you raise your hand so we know that you know how to click that. I am struggling with it. I'm old. So if you can show me, more hands are being raised. That's good. That's good. I'm assuming those of you who haven't raised your hand still or don't have the capacity to do it. Okay. Why don't you all take your hands off now? And now I'd like you to vote. So only a subset of you can vote, obviously, because you can raise your hand. So please take off your raised hand and answer the following question. Is health insurance the answer for low and low middle income countries? I would appreciate it if everybody mutes their computer. So question is, raise your hand if you believe that health insurance is the solution for low and low middle income countries. I only see one hand so far. Okay, so you don't need my lecture. We're done, thank you. So we don't need to go through the session. I might as well do it since I'm here. So let's go through the presentation. So the question was, health insurance in low and low middle income countries, the solution or a bad idea? So I'm going to give you the answer right now. It's a bad idea. I'm going to do so by covering two papers, one recently published and one which is accepted but not yet published. So let me see if I can change slides. Here we go. So we'll focus on these two papers, and it includes quite a bit of summary of literature on the topic of health insurance in low middle income countries. A very simple outline, one slide on typology. It's the typology actually I developed for the second paper, but it presents how we can look at revenue generation and pooling. And then we're going to jump deeply into the first paper, which talks about the challenges of labor tax social health insurance in low and low middle income countries. We'll have a short break for any clarifications, simple Q&A, not too complex at this point. And then we're going to do a second paper, which is the one that's forthcoming, the issue of challenges with contributory health insurance, which is a broader category. I'm being very ambitious. I apologize, but I saw this opportunity to present both papers and I decided to do it. So this is a simple typology of how most countries, or almost, actually not most, all countries eventually transition their health financing. Every country I'm aware of starts with an out-of-pocket spending dominance. By the way, I use the word dominance because there is no pure health financing system. Every health financing system has multiple sources of financing and multiple ways it pools. But we like to think of what's the dominant form. And most countries start as out-of-pocket spending dominance, which is by far the worst way of financing healthcare. We'll talk a little bit about that, although most of you know this already. The more interesting part is every country transitions out of that into some form of pooling. And that's good. We want to pool health spending. But there are two very distinct forms of pooling. One, which I call here non-contributory or budget transfer dominance. The other one, which is contributory or a premium entitlement insurance. This is important to distinguish. There's also ways that it gets mixed. I'm not going to spend too much time on that. Happy to answer questions later if you want. If you think about those two different ways of pooling, the arguments in both papers is that it matters a lot as to which one we use. And that's a debate I've had with quite a few people, including many of my co-authors, until I was able to convince them to go my way. So the most obvious form is non-contributory, which moves into line ministry budgets. A sort of a similar form, it's also non-contributory, so it's a budget transfer, but it's put into a form of an insurance fund. So it takes it out of the line ministry. It gives it some independence as a purchaser of healthcare services, but it's still dominantly non-contributory. That is, money comes from Treasury, from the Ministry of Finance, from whatever form of taxation, but it's not linked to health. The other group, the contributory forms, where there is a premium, so somebody pays a premium, and that premium entitles them to healthcare services, usually to themselves and their family. And the most obvious is what's called social health insurance fund, and we're going to go into deep detail about it in a minute, or like the German model, multiple insurance funds, and the worst by far, private competitive insurance. So these are the different ways you can cluster. And if you notice here at the bottom of the slide, I put in a number of categories. Insurance is, in the most basic sense, very simple, but it can come in so many different forms. It can be mandatory or voluntary, and please God, let it never be voluntary. It's a terrible idea. It could be national, subnational, community-based. It could be single fund, multiple funds, competitive. It could be public or private ownership. It would be comprehensive versus selected services such as hospitals or primary care versus complementary. So insurance comes in many different forms. Let's jump into the first paper. So the first paper, the case against labor tax financing of social health insurance for low and low middle income countries. This was published in Health Affairs in 2020. And I list the authors because I'm so proud to have been able to bring on this conversation so many people much smarter than me. So I got engaged with this topic later in my career at the World Bank. I'm an equity economist, so my focus was mostly on economics of inequality. And health financing I used to teach, but mostly based on published papers by these people who are now my co-authors. Bill Savadoff, at that time was the Inter-American Development Bank, knows more about Latin America health insurance than anybody alive. Bill Shao is a distinguished professor from Harvard University, used to be the chief actuarial of the United States government, has advised presidents and premiers all over the world. Joe Kotzen of WHO, who is about to retire, he's the team lead for health financing in Geneva, one of the most known and loved health economist that I am aware of. Agnes Suka used to be his boss at WHO. She was the director of health governance and financing. Ajay Tandon was my colleague at the World Bank. He's still with the World Bank. He's currently based in New Delhi. Exceptional, highly published health economist. Adam Wagstaff, who we unfortunately lost the week this paper was published, he passed away, is one of the most famous health economists in the world, international, used to be the president of the International Health Economics Association. And finally, and not least at all, Zwini Yip, Harvard University, who took over from Adam as the president of International Health Economics Association. So the reason I list and I highlight this is because I was so worried about what I saw that I wanted to bring the most thoughtful, the most intelligent, the most knowledgeable people on the topic. And to get all these people to agree on this was an achievement that I'm very proud of. So what happened? Why did I get engaged on this? In 2015, 2016, I was managing the health portfolio for East and Southern Africa at the World Bank. And I started hearing from colleagues, we're getting a lot of demand to build labor tax social health insurance in low income settings. And my colleagues were asking me, this makes no sense. You've taught us, everybody's taught us, this is a bad idea. Why are they doing it? And, we tried hard to fight it, but, countries are sovereign. They choose to do what they want to do. So I started reaching out to a number of colleagues, Bill Shao, Ajay Tandon. Ajay was then working on East Asia. He said, it's not just Africa. In East Asia, a lot of low-income countries are moving towards labor taxation. And I don't know why, but they're doing it. I even heard from poor countries in the Caribbean. They're very interested. Haiti. So I was quite surprised. And when I retired from the World Bank in 2017, I started working with a USAID large project. And so I decided I need to understand what's happening. Is this just a few countries or is this a large situation? So we did a scan. We tried to understand what's happening on reform in as many low and low middle income countries as possible using the World Bank categorization, IDA countries, or used to be IDA countries the last few years. We had 48 eligible countries, and we were able to get a scan in 41 of these 48, which is not a small sample. It's almost a census. And to my shock and disappointment, 60% of the 41 countries have either initiated or are considering initiating a labor tax social health insurance, which, as you'll see in a minute, is not something recommended by anybody who knows health financing. And yet, a lot of countries want to go in that direction. And it sort of technically makes very little sense. So we decided, let's dig a little deeper. We selected 8 countries from these 25, and we contacted experts in these countries, and we asked them, you know this is a bad idea. Why are these countries doing this? And there were the 4 dominant answers. One, it's drive for more resources for health. So DRM is an unfortunate acronym, domestic resource mobilization. Many donors are eventually wanting to get out of providing funds, so they want countries to generate their own income. And so there's pressure from donors, including USAID, to push countries to generate their own income. And many countries chose, okay, we'll do labor tax social health insurance as a way of doing it. Another repeated answer was a misunderstanding of what the C in universal health coverage is. Of course, the C in universal health coverage is nothing to do with insurance. It's basically coverage with health services. Insurance is a way you can get coverage. It's not the only way. In fact, it's probably not the best way. There was also interest by a number of countries for financial autonomy. They wanted to get out from the thumb of the Ministry of Finance and Treasury. They wanted to have some autonomy over their financing. And finally, it's an attractive issue to give entitlements. So many countries wanted to have an entitlement system. So those are some of the examples. So the first thing we wanted to do in that paper is that, okay, let's try to understand how did this evolve? And what does social health insurance mean? Because we discovered most people have a confused understanding what social health insurance means. So this whole thing started in Germany in 1883. Otto von Bismarck is in part of trying to unify Prussia, Germany. pushed for a way of getting existing small funds into a national fund or a national mechanism for financing healthcare. So it was the original social health insurance. You have labor taxes, so part of your wages gets straight into an insurance fund which covers health services. And it took 127 years for universal health coverage in Germany to take hold. That followed quickly by Belgium, Austria, and a number of other countries, and it became the dominant form of health financing in Europe. East Asia came in later into the equation, Japan and then South Korea, and they moved much faster to get universal health coverage. Both have labor tax social health insurance, but slightly different than European model, much less generous and requiring a lot more out-of-pocket spending. Latin America then started a huge, almost every country in Latin America in the 1960s started their own form of labor tax social health insurance. So this was phase one of traditional social health insurance. And by traditional, I mean labor taxes funded social health insurance. Then came what I call the reversals. The Americans started doing reversals, delinking labor taxes. So Medicare and Medicaid came in the 1960s. Medicare is a retirees insurance. And so what happens is those who work currently pay taxes, labor taxes, but those labor taxes are not used for those who are working, they're used for those who have retired. So it delinks the labor tax from the insurance. Medicaid is even less linked. This is for people who are below the poverty line, and this has no link to labor taxes in the sense that this is publicly funded to provide healthcare for the poor. So this is moving away from the traditional social health insurance. What is more interesting to me is the second one. In Western Europe, a lot of countries that started with labor taxes moved away. Started with the UK, then Italy, Sweden, Denmark, Greece, Iceland, Portland, Spain. All of them shifted from labor tax dominance to general revenue dominance. And they moved away for labor taxes, earmarked labor taxes. Even France and Germany, the two dominant labor tax countries, started hedging by adding money from other sources of financing. And then there's this experiment in Colombia, which was later repeated in Mexico, which is called an extended social health insurance. So they had a group of people who were covered, the formal sector. They decided there's a whole bunch of people who are informal sector. We need to cover them. So we'll use money from general revenue to cover those who are not covered. So it delinked for a lot of people the labor link. Okay. And the focus of this paper was what happened after that. So in Eastern Europe, there was a return to labor tax social health insurance after the 1990s. When the wall fell down, countries wanted to be like Germany. So they moved away from the Shemasco Soviet model of public financing, public delivery, to some form of labor tax social health insurance. And now we're seeing this push in Africa, Asia, and elsewhere for low and low middle income countries, which is the focus. So the reason I was so surprised is that up to this point, when I started thinking about this, I assumed this was accepted knowledge, settled knowledge. It's a bad idea. And the reason we thought it was a bad idea, because some smart people like Bill Savadoff, who's a co-author of this paper, had written about it for years, and we used to use it in our courses. There's a wonderful paper. By the way, all these papers are linked in my PowerPoint. You can download them easily at the last couple of slides. Bill Savadoff wrote this definitive piece about the Latin America experience and showed that labor tax social health insurance has this amazing combination of inefficiency and inequity. It's a terrible idea. And Latin America is still struggling to get out of it. So I thought that's known. After that, Bill Shaw, who's also co-author of the paper I'm presenting, and a colleague of mine from the World Bank, Paul Shaw, wrote this wonderful book, which again, you can download, which they looked at all countries that have been experimenting with labor tax social health insurance, and some who have been successful, some who have not, and tried to identify what are the pre-existing conditions for success. The next slide will give you that summary. And Adam Wagstaff, who we lost, unfortunately, also had did amazing work on social health insurance in Eastern Europe and in Europe in general, and found very little evidence of added value or success, and quite a bit of evidence of challenges. So at that point, nobody could find publications or evidence that supported labor tax social health insurance. Some donors kept pushing it, but there was no real evidence. So this was a surprise to me that I find out all these countries are pushing into a health system, health financing system, that most experts think is a bad idea. So this was what I mentioned, the Bill Shaw, Paul Shaw framework. They looked at countries that have been successful and said, okay, what are the pre-existing conditions? And here they are. You need to have a large formal sector employment. You need to have high wages and salaries, low poverty rates, small family size, efficient functioning provider networks, strong human resources, strong administrative support, and government capacity to regulate. And you notice most of these conditions do not exist in low-income countries and low-middle-income countries. So again, it was surprising to me that this was happening. So then I had to wonder, why are all these countries pushing for something there's no evidence for? And the only reason I could come up with is maybe there's new evidence that I have missed. I have not focused on this topic in my last few years in my career, so I thought, maybe I missed something. So the paper is trying to say, okay, what have we found out since that first wave of rejections? Fortunately, a lot of work had been done. And this was done by the World Bank. And one of our co-authors, Ajit Tandon, wrote the chapter of this wonderful book, which is called Going Universal, which focuses on how 24 countries around the world have been very successful in moving towards universal health coverage by covering the poor. And when they looked at the data on financing, the wonderful and clear message, none of the 24 countries had used labor tax social health insurance to do this. Most of this, all of this, was done through general revenues. So that left side of the chart I showed you earlier, transfers from Ministry of Finance, not through labor taxes. And so, again, no clear evidence as to why people are going that way. So I thought, okay, maybe universal health coverage is not the standard. Maybe we just want to look at evidence that traditional social health insurance can be useful for domestic resource mobilization. Remember, quite a few countries said we want to do this because the donors have asked us to generate more domestic resource mobilization. So the question becomes, can we increase spending on health by adding this new tool into our toolkit, labor tax social health insurance? Fortunately, the World Health Organization, working with other agencies, had just published work in the journal I edit, Health Systems and Reform. They looked at all experience with increasing domestic fiscal space for health, increasing spending on health. And said, wonderful. So Hélène Barrois was the lead author, and others had worked on it as well. But then there was a commentary which included people from the World Bank, Ajit Tandon, Christoph Korowski, and Global Fund, Michael Borowitz, the chief economist. And their message was quite clear. The successful examples of expanding resources for health comes mainly from macroeconomic growth and from reprioritization, not from earmark taxes. Again, no evidence that labor tax social health insurance has increased spending on health. Another thing I wanted to look at, which is what people said, is maybe it's just a first step. You can use labor taxes to at least get the ball moving. And this expression, which we have in the US sometimes, if you build it, will they come? So at least you start. It's the entry point. So don't be too harsh. If you start with a small fund, over time you build it. So I looked, is there evidence in low and middle income countries of a country that's been for years doing this approach, build small and grow it? At the same time, a wonderful paper was published by fantastic health economists in Kenya. And they talked about the Kenya experience, which initiated labor tax social health insurance for hospitals in 1966. And by 2018, which is 52 years later, it's only covering 14% of the population. So no, if you build it, they will not And we'll talk a little bit about it later as to why this doesn't happen. Kenya, like many countries, started with the formal sector and said, okay, then we're going to open it up for people to purchase on a voluntary basis. And you'll see a little bit later, there's zero evidence that voluntary health insurance works. And so again, we didn't get anywhere. So in summary, for the first paper, most of the successful factors, labor market capacity, do not exist in low and low middle income countries. It pushes informality in the labor markets. Employers don't want to pay higher taxes. Employees don't want to lose money from their paycheck. It fragments financing, as we saw in Latin America, and increases inequality, creates a two-class system for financing and benefits, increases inefficiency, it drives up cost. We can talk about that later as to why that is the case, but the evidence is overwhelming. And there is little evidence that it increases domestic resource mobilization, which is the main motivation. So these are all the papers that I had mentioned, and for this paper, I have all the links. So the first one is the paper itself. You can download it and read it. And the others are the resources I used for the paper, and you can download them all as well and read them if you want. Why don't we take a minute and see if you have any questions? Let me stop sharing for a minute and see if you have questions. And I see we have 58 participants so far. This is pretty good. I'm happy. Any questions? I see a chat. Jacopo mentions, can you cite evidence? Absolutely, for the pushing informality. In the second paper, I'll give you the link to the evidence. It's overwhelming.
Thank you, Dr. Abdul. We have one participant raised his hand, Dr. Saim Ahmed. So I'd like to tell Sambek, could you please unmute yourself and ask your question?
Yeah, thanks for the nice presentation and introduction to this topic. I am Sam Ahmed, working at University of Glasgow and also member of the Bangladesh Health Economics Network. I just have a observation, maybe in the Bangladesh context. We have the problem with the general tax and also the labor tax as well, because the as we know, the tax collection in Bangladesh is very poor. Even in the South Asia, we have lowest collection of the tax. So any system based on the general tax will not be viable because government has other competitive spending as well to make. And also because of the large informal economy, we have a small amount of people who has formal income. So what can be the best source of money for health sector in Bangladesh? I just want to know your observation in this case.
Big question, which we can address at the end of the presentation. But please accept the fact I haven't been in Dhaka in quite a few years. I've been there 18 times, but not in the last 5 or 6 years. So I feel uncomfortable giving country-specific advice, but happy to talk about how you can think about sources of financing. There was a question from Mariam saying, was there any key factor which made the countries realize that it doesn't work? Yes. The evidence in Latin America is that it has increased inequality substantially. And this is part of the world which is the most unequal in the world, Latin America, but it's also inefficient. So it's a form of financing that increases inequality and inefficiency. It's the golden duo. It's the last thing in the world you want to do, is do something that makes you less efficient and less equitable. All right, if there are no other, there's Jacobo, you want to say something?
Yeah, sorry. I do have a question on extended SHI. Just to clarify the meaning, does that mean that there is a start with contributory SHI and then we get part of it funded with general tax? Or because that still brings some fragmentations, right? Still, there's going to be a different pool between those that are funded by the general tax. So in my head, it seems more reasonable to just just continue and expand the general revenue flow.
Not sure I understood the last part, but your first part is correct. Most of all extended social health insurance are based on systems that have labor taxes, in which the government realized, oops, the formal sector is not growing. So we have more than half the labor market uninsured, and we're creating this dual system. So Colombia was the first country to do it, but other countries have followed since. Mexico is the largest country to have done it. And then they basically subsidize or completely provide for free health insurance to those who are not in the formal sector. An interesting story, Colombia, politically, it's been such a challenge. Since 1993, every government has struggled to keep this going because there's been this attack on it. And it's mostly people who are paying the labor market are unhappy about having to subsidize those in the informal sector. Mexico is an even worse story. When the new government came a couple of years ago, they completely eliminated the extended social health insurance. So they completely killed the project which had created, it's called Seguro Popular, completely eliminated it. Let me jump to the second part of the presentation and go through the second paper, which is forthcoming. So the second paper is called Addiction to a Bad Idea, especially for low and middle income countries, contributory social health insurance. A lot of the authors of the first paper joined me for the second one as well. Agnès Souka, who's no longer with WHO, she's now a director at the French Development Agency. Ajit Tandon from the World Bank still as a co-author, Joe Cutson from WHO, who's about to retire still. In addition to that, we added Cheryl Cashin, who's an exceptional economist. She's the managing director for Results for Development. Julia Watson, another wonderful health economist who used to be with DFID, retired and now was working with Abt Associates. Two people from the WHO Euro office on health financing in Barcelona, Sarah Thompson, fantastic health economist, and Tamas Everitis, who's actually the director for that group. And finally, my colleague at the World Bank, Shonnam Gien, a lead health specialist. So again, I wanted to make sure I get people who are smarter than me, because I wanted to make sure I'm not stepping out too much outside my comfort zone. So for this paper, we focus on the whole right side of this chart. This whole premium entitlement insurance, whether it's labor taxes, which is the dominant form, or it's just people who pay premium through complementary, supplementary, or other forms of voluntary even insurance, like in some parts of the US. So the idea now is not just focus on labor taxes, but any way that links premium to entitlement. You get healthcare if somebody pays for you or you pay the premium. So, economic rationale, the most obvious fact that I see in country after country is what is called the 60-10 principle. So in every country we have data for, we find this amazing repetitive number. 10% of the population ends up using up 60% of spending on health. So those who get sick, get really sick, and use up most of the resources. This is perfect. This is why insurance function is needed. So this is economic theory that says, yes, we need to pool funding because we cannot rely on out-of-pocket spending because those 10% will go bankrupt. So you need to spread the risk. And, you know, in general, you want to subsidize low-risk people, subsidize high-risk people, rich subsidize the poor, and you need these subsidies across the age groups. The very young and very old require a lot of healthcare. Those in the middle don't. So it makes sense to have some sort of an insurance function. But when you look at the actual evidence of health insurance as a mechanism, because pooling is an insurance tool as well, but if you think about the premium contribution insurance, the evidence in economics is overwhelming. In fact, 2 Nobel Prizes for economics were awarded, one to Ken Arrow, one to Joe Stiglitz, for part of the work that's showing that market failures for contributory health insurance. I don't want to spend too much time on this, but happy to answer questions later. Contributory health insurance will likely fail because of adverse selection, in the sense that people who are choosing to enter choose so because they think they're high risk, if it's voluntary, but also risk selection. Insurance companies can only lose money if they insure a lot of sick people. So risk selection tells me that insurance funds will try to get rid of these 10% who are costing them the most. There's also empirical as well as theoretical reason why it's inequitable, but let's go into the empirical numbers, because we can talk about the theory why health insurance or contributory health insurance is inequitable, but let's look at the actual data. If you look at equity, you think in terms of both access to care as well as financial protection, the data is overwhelming. So overwhelmingly, countries with contributory health insurance experience gaps in coverage. So there's a large cluster of people that don't get insurance. And guess who these people are? Low income, informal workers, and people who are unemployed. So by definition, empirically, a contributory health insurance will increase inequality. That's data from 40 countries in Europe. A wonderful study by my colleague Adam looked at data from 111 countries. It shows overwhelmingly, if you're interested in financial protection, which is an important function of health systems and health financing, most of it, if not all of it, comes from budget funding, not from contributory health insurance. So if you look at almost the whole world, there is very little evidence that contributory health insurance actually has improved financial protection, at least nowhere close to what we get from budget transfers. There's a wonderful recent paper I love, looked at data from 36 sub-Saharan African countries, shows health insurance reaching only low levels of population and mostly for the better off. So this is even more evidence that in low and low middle income countries, insurance doesn't seem to work for poor people. It seems to work for a very small slice of the population in low income countries and low middle income countries, and for those who are usually better off, the wealthier. So again, it increases inequality. A paper I contributed to, but the lead author is Julia Watson, is that we looked at 15 years of published research, testing the extent to which health insurance systems which were designed, so these were health insurance systems which were designed to address inequality, and found that most of them fail. They do not increase equality. In fact, quite a few increased inequality. So very little evidence that this is an instrument that seems to work for equity. And this one you've already heard from the last paper, the book from the World Bank, Going Universal. Actually none of the countries that had been successful towards increasing coverage for the poor had used contributory health insurance. None of the 24 countries. So another thing we look at is, does it add resources to health? Again, in the last paper, we looked at the WHO review. The answer was a clear no, but also other reviews. So Fan and Savadoff and Smith, Hudson et al., Wagstaff, Moreno Serra, and all these papers are listed at the end, so you can download the papers and look at them yourself. Overwhelming evidence that budget transfer is the mechanism for increasing resources for health. It is not contributory health insurance. Even in the wealthier countries, budget transfers are the sources for additional revenue. And this is data from WHO Global Health Expenditure surveys, and they look at wealthy countries. This is the highest income countries in the world last 20 years, from 2000 to 2020. If you look at the growth of health spending, it comes under the blue bar, the blue shade, which is government budget. Social health insurance, which is in orange, grows, but it grows much less than the budget spending. So even countries that are designed to be able to handle contributory health insurance, most of the increased spending comes from general revenue. Does it increase efficiency in the health sector? Again, the two regions that have done this the most, the answer is clear no. The Latin America example we talked about earlier, it increases inequality in a fragmented both health financing and health service delivery. So what happened in Latin America is once you started garnishing taxes from labor, those who are in the formal sector demanded better services. So a parallel system of service delivery was created. So you have Ministry of Health hospitals, and you have social health insurance hospitals. And guess which one was better quality? So not only are you fragmenting financing, you're now fragmenting service delivery, and you're increasing inequality. Wagstaff and others found very similar results in Eastern Europe, where there were a number of countries that moved towards contributory health insurance. Impact on labor markets, and somebody had asked if you have papers on that. Absolutely, and the citations are Wagstaff, Levy, Wagstaff, but there are others. What happens in labor when you have a contributory insurance through labor payroll taxes, it increases the cost of labor. It tends to increase pressure on informality because both firms and workers agree to opt out of the formal sector. Though even worse when it's voluntary contributory health insurance. And again, the papers I list here are papers you can download. The citations are at the end of the paper. Overwhelming examples of failure of voluntary health insurance. And we sort of touched on the reasons for that when we looked at the economic theory slide. There's also practical and historic factors. So most success in contributory health insurance requires that the public sector change. It should be a regulator and supervisory function. But most low-income countries and low-middle-income countries have very weak regulatory and supervisory function. So you're putting even more pressure. Most of these countries don't have strong actuarial accounting services, which are critical for health insurance to function. Most of these countries don't have a very strong financial sector, which is important for reinsurance functions to protect the insurance system. Also, most of these countries have higher levels of poverty and high levels of informality. There's a historic context here. Europe, when Germany started the labor tax and contributory health insurance, it based it on 600 years of experience of some form of contributory health insurance, usually private around professions, guilds. And so since you have 600 years of experience, it sort of became natural to move into a national program. There was a culture of this kind of contributions and governance. It's a hard thing to take that and apply it in a country that did not have that. That's why these systems don't work very well outside Europe. And the two countries that have been incredibly successful in East Asia in building contributory health insurance did so at a period of time where the economies were growing like crazy. And so when you have a fast economic growth, you can do whatever you want. And so they had the ability to quickly move up, plus they're higher income countries. Japan surely was, and South Korea was becoming a high income country. And here are the references that I mentioned, quite a few of them, which you are welcome to download. Hopefully the paper will be available shortly and I can send you a link. Thank you, and let's see if you have any questions. And sorry for going so quickly. I was just ambitious and I wanted to get some of these to you as quickly as I can.
Thank you, Dr. Abdul. It was indeed interesting listening to you. And now we are almost at the end of our webinar and for the question and discussion section. And I would like to invite all our participants to put the questions in the chat box, and as well as if you want, you can unmute and speak to our speaker. Thank you.
Hi, thanks for that. It was a really interesting talk. I guess you've given a lot of critique about why social health or health insurance is not the way forward. What do you see as the way forward for low and middle income countries in healthcare financing? I realize that's probably a very big, broad question, but
yeah, it's quite simple actually. As I mentioned, the WHO actually studied this and put out a fantastic paper, which I cited in the first paper. And then the World Bank, Global Fund, and others have signed up to it. The evidence, you have to go with evidence, right? So it's not about what I think or my theoretical purpose. Where's the evidence? Have countries increased spending on health? Yes, quite a few countries have increased spending on health. How did they do it? There are two ways they've done it. One, their economy grew, and therefore they can spend more. Great. If your economy is growing, you don't need to worry too much because a rising tide lifts all boats, so you can increase spending. Other countries did it differently. They actually prioritized health. You can think of Vietnam as a fantastic example. They basically decided we're going to increase spending on health and prioritize the health sector. So those are the two proven methods of increasing health spending. And what the WHO, the World Bank, and others have recommended, you need to do a study in every country you're interested in and say, okay, what is the most likely place for you to increase spending on health? Is it economies are growing? Is it that you can reprioritize? Is it you can improve efficiency? It's called fiscal space studies. That is, you need to identify country by country, how is it they're likely to increase spending on health? And then use examples from countries that have been successful. So it's not about, let me find a pot of money. So for example, one of my biggest frustrations is consultants come to a country and say, let's do innovative financing. There's no such thing as innovative financing. It doesn't exist. It's, I apologize for my French, but it's crap. There is no such thing. It doesn't work in environment. It doesn't work in housing. It doesn't work in any sector. Their idea of innovation is let's tax something. Let's tax sin taxes. Let's tax health taxes. Let's tax airline and then get money. Well, there's nothing innovative about it. You're just earmarking taxes. And so the answer is simple. You do the country's fiscal space. You see what are the likely spaces. You try to convince the Ministry of Finance that if you give us the money, we'll be more efficient. And you need to show them being more efficient. So Agnes Souka, when she was the director of Africa Development Bank's Health, Education, Social Protection Group, Human Development, did a wonderful program called You Need to Increase Money for Health and Health for Money. And that's a balanced equation. If you want Ministry of Finance to give you more money, show the Ministry of Finance that you're getting more health out of the money they're giving you right now. And so that is how you increase resources for health.
Thank you.
Thank you. Thank you. We have one more raised hand in the participant list. Dr. Sam, would you please go ahead?
Yeah, thanks for the nice presentation. And I find a lot of materials and references to go through, and I think that will be very useful for me. And I have one question that is, I don't have much knowledge about the labor tax. It is interesting to see that it is linked with inefficiency. Is there any specific feature of the labor tax that causing the inefficiency, or there are management or fragmentation issues that causing this inefficiency in the system?
So the inefficiency story can be put in different ways. First of all, from a purely finance point of view, so from public finance point of view, the last thing in the world you want to do is fragment your tax system. So you do not want to have a health insurance, a tax for health, a tax for education, a tax for roads, a tax for environment. So if you fragment how you generate resources, you are automatically increasing inefficiency in how you generate revenues. And so most finance economists will tell you, please let the government group that's in charge of revenue, which is the Ministry of Finance, be in charge of determining which combination of taxes they need, instead of every sector suddenly becoming tax experts and saying, I want my tax to do this, and I want my tax to. So that's one element of it. There's also an inefficiency that comes from creating this separation between the funder and the payer and the contributor. This is the second Nobel Prize in Economics. It was won by Joe Stiglitz. It's basically called asymmetric information. You are creating systems in which the funder doesn't know exactly what the provider is doing and doesn't know exactly whether the patient is behaving the right way. Are they smoking? Are they exercising? And so you create these levels of asymmetric information, which creates inefficiency. There are many other ways to look at inefficiency. Something I found interesting in a number of countries, if you have a competitive insurance model, it seems to increase spending on technology. So if you're an insurance company and wants to attract people to buy into your insurance, you can tell them, "Ooh, I have CAT scans that you have access to." So guess what happens? Suddenly, private hospitals start buying much more CAT scans and high-end technology than the country needs. So it ends up increasing spending on health in an unsustainable way. So there's a number of different ways contributory insurance, labor taxes, or any form of insurance system increases in efficiency. It's a complex question, but at least I gave you a sense of that, I hope.
Yeah, thanks for that answer. And one follow-up is after the fragmentation, like tax for different sector, it will also increase the cost for collecting the tax, and that can be one of the sources. Yeah, thank you.
Absolutely.
Thank you, and thanks for the question, Dr. Sam. And always, I would like to request the participants, you can send the questions with us over email, and we can forward the questions to our speakers. I can see there is a large question in the chat box from Irene. Irene, would you like to unmute and just summarize what you would like to say?
Okay, thank you. I thought because of the time, I just stick it in the chat box. No, I was just saying, I totally agree with the speaker that these things are known, and you do introduce a lot of inequities. But I think part of the confusion is coming from the use and meaning of terminology. Because in Ghana, for example, we talk about health insurance, but right from the beginning, for those of us who are involved in the advice on this scheme, we fought to run away from kind of a contributory classical insurance, and 70% of it is tax funded. But still, there is a component which is contributions from social security funds of the employed, but they all go into one single fund. We still have inequity problems, but the inequity problems are coming from other design issues. So I guess, to cut a long story short, I think it's some of the confusion around terminology. So somebody picks health insurance and they don't realize that the term health insurance is used by different people with different framings and different meanings. And one meaning is, then they run with the meaning and they don't realize actually the same thing means different things. It's a difficult problem, very difficult.
100%, which is why I start every one of these papers by defining the terms, because there's so much confusion. What used to be called social health. So, for example, a number of countries tell me that, oh, South Africa is starting a social health insurance system. So, no, South Africa is starting a national health insurance system because they're not tying it to labor taxes. And so just simple terminology is confused. And if you remember in my first slide, there's so many different dimensions to insurance. And so it's important to be very clear what we're talking about. 100% agree.
Yeah, thank you, Irene. I can see one hand from Jacopo. I'm just concerned about time, so that would be our last question. Jacopo, do you please go ahead?
Thanks. I'll be quick. I might send some further questions to Abdul afterwards, as I just wrote a paper on this topic. The question I have is regarding labor tax, and I am not so clear on the implication of a system that is funded by labor tax, or what could be the implication. And what I mean is, if the system is not contributory, in a non-contributory system, for example, like Italy, that went away from the original contributory system, still 50% of the revenues come from payroll and social security contribution. So there's still labor tax. So what I'm trying to say is, it's probably more binding that the system is non-contributory rather than where the money is coming from. Or is there another pathway that I might not see from where labor taxes could impact health?
You're absolutely right. It's as a general rule, as a health economist, I don't care where the money is coming from, as long as it's coming from the general revenue pot. How a Ministry of Finance, how a Treasury chooses to tax people is completely up to them. I would not push for labor taxes for the simple reason for, I wouldn't worry about Western Europe because informality is not a huge issue. I worry for developing countries, which is why both papers I highlight low and low middle income countries. And the reason the first paper is focused so much on labor taxes, when you're talking about a country where less than half the population, less than half the labor is outside, or less than half is in the formal sector, it makes zero sense. And most of these countries, I mean, I got this paper from Haiti suggesting that Haiti should start a social health insurance, labor taxes. Most labor in Haiti is unemployed. What do you mean to start a labor tax, social health insurance, when the majority of the labor market is unemployed? And so that's the problem for low and low middle income countries. For upper income countries, whatever combination of taxes the Ministry of Finance can do, it's completely up to them, and it should be their job, not those of us in the sectors, to document it. Well, it was lovely being with you. I hope this was of interest. I'm happy to answer some questions later on this week. If other questions you can send to the organizers, they can send to me. I will do my best to answer them.
Thank you so much, Dr. Abdu. It was indeed, knowledge enriching for the participants, and obviously a lot of interesting discussion that took place. And the discussion actually helped us to come across with the most recent literatures in the particular field. So we are almost at the end of our webinar, but I would just like to spare some minutes, because we have the advisor of Health Economics Research Network, Dr. Simon Walker from Center of Health Economics, and also the convener of Health Economics Research Network, Professor Rumana Hawk, with us. So I would just first like to invite Dr. Simon Walker to just briefly, say the role of Center of Health Economics for the Health Economics Research Network.
Thanks very much, Abdullah, and thanks very much again, Dr. Abdullah, for a really, really interesting presentation. It's fantastic to see so many of you here today. So just quickly, obviously, much of the work to set up the Bangladeshi Health Economics work goes to Professor Umana and colleagues in Bangladesh, but CHE in York is very proud to support it as part of our Global Health Capability Growing Programme. This is the second of what we hope will become a successful series of webinars, which we're very proud to support. And they've both so far been really interesting and really informative. And I hope it continues in that way. And it's great to see so many people here. And we hope it continues in such stead. And I'll pass over to Rumana, Professor Rumana.
Thank you, Dr. Simon. Over to you, Rumana ma'am.
Thank you. I would really like to thank Dr. Abdu Yazbek for giving us time for the fantastic presentation, and he just agreed to join. So really, really grateful to Dr. Abdu. I hope that you will be with us and take part in follow-on discussions, and we will be very happy to share your presentation and the audio to all the participants, as you can already see the request coming from the participants. And all the participants, I really appreciate your support to Health Economics Research Network. We'll continue these webinars, the monthly webinars. We have just started, so your support and patience will be appreciated. And if you really want to hear on any specific topic, please do let us know. And Dr. Simon, me, and other colleagues, Health Economics Research Network Secretariat are working to identify the possible topics and the resource persons. So your feedback will be very helpful for us to arrange future webinars. So on behalf of Health Economics Research Network, I thank you all once again for joining. Have a nice evening. Thank you, everyone.
Thank you, everyone, for joining, and we request you to stay tuned and stay safe. Thank you so much.